everyone, Heather here. So back in the days I used to float around a lot from hospital to hospital or unit to unit, and it was usually against my will, but I didn't put up too much of a fight because I usually like to be a team player and make the best of the situation. But actually, floating from hospital to hospital was my decision, so I can't really blame anyone for that. But when you come into work and you're working on this unit and you know you're going to be working with all your favorite people and then they tell you you're floating somewhere, you're like, crap, I don't want to work today. So one day I come into work and they tell me, oh Heather, you're going to be floating to the ICU. And I was like, no, there must be some kind of mistake because I'm not an ICU nurse. I don't deal with those beeping vent machines. No, it's not going to work out. You gotta find somebody else. Unfortunately, they wouldn't let me out of that one, so I ended up going to the ICU and taking care of 2 med-surg cardiac patients that we would have normally taken care of on our floor. So I was like, all right, I can handle this. But taking care of 2 patients in 12 hours is not ideal. The clock will not move at all. But other than that, it was a great day. It wasn't as scary as I thought it would be, and I would do it again if I had to. I've often been floated to the general surgery unit, which is mostly abdominal surgeries like appendectomies, cholecystectomies, colon resections, and maybe some bladder surgery. Of course, pain management's a priority. A lot of times they'll be on a PCA pump to control their own IV pain medicine the first 1 or 2 days, and then after that they'll be on Roxicodone, Percocet, or Vicodin every 4 hours. But all that anesthesia and pain medicine can slow down the gut post-surgery, so it's important for us to assess their bowel tones and ask if they're passing any gas. Most patients aren't allowed to eat or drink anything after abdominal surgery until they have audible bowel sounds. And then we can give them ice chips and clear liquids and advance their diet as tolerated. If the gut is asleep or not moving properly, the patient could develop a paralytic ileus, which is malfunction of the nerves and muscles in the intestines that impairs movement and digestion. So if a patient happens to eat something when their intestines aren't moving, then they're just gonna develop a blockage because that food's just gonna be sitting there like a blob. And then we have more problems. Signs of an ileus would be abdominal distension, nausea, vomiting, spasms, and constipation. If there is a suspected obstruction, it would have to be confirmed by abdominal x-ray. And if there is a true blockage, the patient would most likely have to have a NG tube inserted through their nose into their stomach to decompress the abdomen and take out all the extra fluid and gastric juices, which can sometimes be like a liter of fluid. It's crazy. I've had a few paralytic ileiuses in my lifetime as a nurse. Not personally, but I've seen a few in the hospital. One unit I really enjoyed working on was the ortho unit. I learned a lot about knee and hip and spinal surgeries. It's a lot of physical work trying to get those patients out of the bed into the chair and following all those hip and spinal precautions. Having a post-hip surgical patient always made me a little nervous. I was scared to move them because I didn't want the hip to pop out in front of me. Not that I actually see it popping out of the socket, but just thinking about it's kind of creepy. I always thought taking care of ortho patients was pretty predictable. For the most part, they're medically stable, so the main issues are pain and constipation. One of the great things about nursing is there's so many different areas where we could work and learn from. Well everyone, thanks for watching. Talk to you soon, Kay? Bye!